I think our next speaker is waiting to join us. I'd like to introduce Professor Jason Leach. He has worked for the Scottish Government since 2007 and in 2015 was appointed as the National Clinical Director in the Health and Social Care Directorate. He, in 2011, was voted the UK Clinician of the Year, and I'm looking forward to hearing his insights into COVID-19 research, the evidence, and national response and messaging. Thank you very much, Professor Leach, for joining us today.
Hi, everybody. I'm Jason Leach. I'm the National Clinical Director of the Health Service in Scotland. And I'm so sorry I can't be there in person. Maybe next year we can correct that. It's not a part of the world I know well. I've passed through, but I'm sure there is much to see. Maybe not in the middle of November, but nonetheless, I'm sorry I can't be there. I did just come back from the Western Isles off the west coast of Scotland on a 3-day trip to thank the staff across all the islands. And I think basically I just got blown from hospital to hospital by the wind. So I'm hoping you're getting slightly better conditions than that, but it was rough. And now back in Glasgow feels like a bit of a relief. So in a busy day, and I know you've had lots of other talks, my gig and instructions were to talk about response, COVID response, both in terms of what Scotland's done and maybe some lessons for other places. I don't have the answers. I have some increased experience. So I'm going to give you some of the things I think that I've learned as an individual and as a leader, whatever that might be. And maybe some of that is transferable. If not, go make a cup of tea. Nobody will think any the less of you. And you've missed 25, 30 minutes of your life. But I hope there is something here that's maybe transferable to your context. I can't walk in your shoes, you can't walk in mine. We have different jobs, different roles, different contexts. But there is a similarity in what we've had to face, isn't there, over this period. So let me just see if I can share my screen, hopefully, and we'll get started. So this is Tedros. You should be able to see him now. He's the Director General of the World Health Organization, and he was in the seat that runs public health for the world when the music stopped. There have now been 250 million infections and over 5 million deaths. This is a once in a century experience, hopefully not for another century. But nobody alive has lived through this previously, unless you're over 100 and you remember the Spanish flu. And this is different from Spanish flu. It's a coronavirus. It's come at a time when we have global travel and we have a large population around the world. So it is different from previous pandemics. The definition of pandemic is an infectious agent that is a risk to every human on Earth. That's quite a high bar. And the WHO declared it a pandemic, as you know, and hasn't reversed that decision yet. We are still in the middle of whatever this pandemic has in store for us to come. And there's a whole other lecture in there about variants versus vaccines versus everything else, but that's not what we're going to do today. Leadership is about everyday activity, isn't it? It's about helping other people. It's about service. It's about delegation, but somebody clever said the true test of leadership is how well you function in a crisis, both as an individual and as teams of people. And that's where I'm going to try and go. And these are my 3 lessons. Lesson number 1 is to understand the problem. And the problem is not always exactly how it seems, particularly if you get your news from tabloid newspapers or only listen to the politics and only listen to 2 sides of maybe a very, very strong argument. Lead. So step up. Now that might be in a ward, it might be in a research group, it might be in a government. Lead, step into the space and try your best to lead. And then my 3rd and short one at the end is to breathe. Look after yourself and look after others, and we'll come to that over time. So let's start with number 1. Let's try and understand what this thing is, what it is we've been trying to deal with. So this is the grass market in Edinburgh. European capital city, half a mile from the castle. Some of you have maybe been there. It's a popular tourist haunt and a local haunt. It's got comedy clubs and pubs and restaurants and hotels. And this is it on an average Edinburgh day in the spring or the autumn with a very rare blue sky, but you'll notice people still have their coats on. This is it in April 2020. We closed it down. We closed everything down, as did you, as did pretty much every country in the world. We put everybody back in their houses. We told them to leave only for care, shopping, essential shopping, or exercise. It's almost hard to believe even now that that was the decision we had to make on the advice of the clinical advisors such as me. And we did it to buy ourselves time. We didn't know what was coming. We didn't know what this was. Every country in the world had flu at the top of its risk register for a pandemic, including the WHO and the rest of us. But it wasn't flu we got. We got a novel coronavirus that didn't have a name when we shut the countries down. We didn't know what it did. We didn't know who it killed. We didn't know how to protect ourselves fully from it. We knew some things quickly, but now, nearly 2 years on, we know a huge amount more of what we're dealing with. But even now, the research changes every day. New research today on vaccines and vaccine waning. And so every day, there is more and more research and knowledge. And we've had to play that science out in real time. Some of us have had to play that science out in real time on the telly. I've done about 700-800 live media appearances during this period, sometimes alongside our First Minister at a podium, sometimes in live interviews on the radio and the television, principally in Scotland, but also in other parts of the world, including even in England. And sometimes the story has changed while I've been on telly. The research has developed in real time. So the first question we have to answer if we're trying to understand what it is we're doing is what's the problem we're trying to solve? What's the exam question? Well, if the exam question was to reduce death from coronavirus, it'd be relatively straightforward. It would be lock everybody in their houses and send them food parcels. That would get rid of the virus. The Winter Olympics has just decided to put all of its volunteers in isolation for 3 weeks to ensure they are COVID-free before they release them into helping with the Winter Olympic athletes and staff, etc. So we now know enough to get rid of coronavirus. The problem is you have to do that while reducing the non-virus harms to the population. And that's the understanding that you have to come to. In Scotland, we call that the 4 harm framework. And there are 4 elements. First harm is COVID harm, direct death and destruction from the COVID virus. Harm number two, the impact on other health and social care. And that's the harm all of our countries, including yours and mine, are now feeling. Postponed care from us, we postponed it, but also postponed care because individuals didn't come forward. Some of that was because they were scared of COVID. Some of it was because they didn't want to bother us. But that postponed care now needs done. That's the backlog. And that backlog is real people with real disease, with real pain, with real cancer. Harm number 3, social harm, the loneliness of older people, the education loss for younger people, the fact that we've had no dentists qualify in the last year in Scotland because we paused the course. All of those things added up together create family, social, and everything else that you understand, probably some of you personally. And 4th, the raw economic harm, the unemployment, the grant applications, the GDP growth or otherwise, people who have lost businesses, restaurants, clubs, etc. So when you try and deal with COVID response, you have to think in a 4 harms lens. It's all very well having the public health advisor, one of them, giving advice to the First Minister, but beside me is the chief economist, and he gives the economic advice. So what does that look like if we unpick it in terms of data? So this is very straightforward data on deaths, the 3 waves of the Scottish pandemic and the number of people who have died across those 3 waves. So this is harm 1, direct harm caused by the virus. And you can see vaccines have completely changed the game. So early 2021, deaths began to fall. And now, even in a very significant 3rd wave for case numbers, higher than we've had previously, we're still seeing many, many fewer deaths than we saw in wave 1 and wave 2. Still too many, 20, 30 a day here. And you can see it's still a disease that kills the elderly and those with underlying conditions, principally. So young people tend not to be seriously unwell, tend not to die, but they do catch the virus and they can, of course, spread the virus. The virus only wants to move to another person. It doesn't care about anything else. So number one is understand harm one. Now understand harm two. So this is emergency or planned admissions. These are postponed cases, either by us or by the patient. So the top one is emergency admissions. So we didn't tell emergencies to stop coming. Some of that is because nobody was out on their bikes and there were fewer cars on the road. And so emergency admissions fell off a cliff in lockdown number one way back in March, April 2020. But it stayed low for over a year. Some of that is people just not coming. It's picked up a little bit more recently as society has returned. And then the planned admissions along the bottom is the stuff we stopped, the cataracts, the hips and the knees, the cancer screening, the things that unfortunately we had to postpone that is now beginning to catch up, but still planned admissions are still not at the same level they were at pre-pandemic, as you can see. So that's harm two. Harm three, there's multiple graphs I could show in here. This is school absence. So this is kids who were not at school. The light blue is COVID. The darker gray is non-COVID. So normal illness and falls and trips and everything else that you would expect in a normal year, although maybe higher because of COVID. But underneath is the COVID we've added to that. So that's some of your kids off school, some kids that my wife teaches in schools in Scotland here off school because of COVID and missing education, missing exams. And of course, crucially, missing the social elements that school brings, the choirs, the school shows, the discos, everything else that school is, trips for 2 years now. And that has direct social harm for these young people. And then the fourth harm, raw economic harm. This is crisis grant applications to social work departments. Quite a high bar to get this money. And you can see in the grey lines where these crisis grants normally rumble along about 15, 20,000 a year. But in lockdown number one, in the dark blue, it doubled. So this is families asking for money to put food on the table or clothe their kids. It's a pretty high bar. And even now, with the economy recovering, with people back at work, you can see we're still significantly higher, 50% higher than we were pre-pandemic. That's people struggling to survive financially. Some of them will have lost their jobs. I'm sure you'll have spoken to individuals or others, or taxi drivers, or delivery people, the way the economy has had to try and adapt. So that's my first lesson. Understand what it is you're dealing with. And it is more complex than it perhaps first seems. It's not just direct COVID harm, it's everything else. So when we're trying to respond, whatever that looks like, you've got to think in those broad terms. My second lesson is an encouragement to lead, is to move forward. Now, I don't know if you're anything like me, but this is sometimes how that's felt. I'm felt a little bit like Homer Simpson. And I have imposter syndrome. I don't know how I ended up in the rooms I'm in, and I'm trying my best to tell the truth every day, give the truth to the First Minister and the Cabinet, but also to the public of Scotland to try and help them guide their way and our way through this pandemic. And I reminded of my mother when I was a little boy coming down to my height and telling me one day, I can't remember what I'd done wrong, but she said, at times of crisis, son, revert to the truth. And I think that was pretty good advice, and I've tried my best to follow it. Now, there's an organization in America, you may have heard of it. I worked for them for a spell when I was a fellow there, and we now have a partnership with Scotland, and it's called the Institute for Healthcare Improvement. They're a global systems improvement organization for health and social care. And one of the things they do is publish white papers of their key thinking and instructions and learning and research. And they have one on leadership, and I think it's a terrific piece of work. It's now a little bit older, but one of the parts of it is how you should be as an individual leader. That's what I quite like about it. It's not about the organogram or what you should have in terms of staff. It's about how individuals should behave. And these are the 5 behaviors. I've used them quite often for leading or in talks or coaching in health and social care. But can I apply them now in this strange new world I'm now existing in? And I have tried. So here's my version of leadership inside the pandemic. So person-centeredness is number one. Person-centeredness usually is about the individual. It's been about, I'm a dentist and oral surgeons. So I fixed broken jaws, and cancer of the tongue, and wisdom teeth. So individual care was where the person-centeredness was. It was about the caring for that person and their family and their carers. COVID means you need to think about what matters to the population. So person-centeredness now shifts a little bit. It moves to think about what that might look like in terms of population health as well as individual health. So the kind of lens through which you see person-centeredness is slightly different. One of the things we've done in Scotland is we've talked about increasing the number of video conferencing appointments that we use, and we call that NHS Near Me. And it's just a neat little story of that person-centeredness. The individual down the bottom, in the bottom right, is Claire Morrison. She invented this system pre-pandemic, and we moved from 1,500 a week to 50,000 a week very quickly because she had done quite a lot of person-centered work. And to our great surprise, when you asked families and patients what they wanted in a video conferencing facility, and remember, we have massive distances. So we have people in Thurso, and it's a 3-hour drive to the nearest hospital in Inverness, and then a 3-hour drive back for what might be a review or something very straightforward, a test result that could be done over a video conference. The patients and families asked to speak to a receptionist. They wanted a receptionist. We thought they can't possibly want to speak to a receptionist. That's crazy. But they did. They wanted to speak to a human being, not just see a little circle revolving on their screen. And clinicians wanted to build video conferencing into their normal clinic. They didn't want to do a whole day of video or a whole day of live. They wanted to intermingle them. And that's what we did. So now if you're at an outpatient clinic, you might have 3 patients live, couple of patients video, couple of live, it's all together. And you see the same receptionist, whether you're live or videoing in, and you see the same care team, whether you're live or videoing in. And it works an absolute treat. It works really, really well. And people have really embraced it. So that's person-centeredness in COVID. It's slightly different from pre-COVID person-centeredness. Frontline engagement has been very, very different. Frontline engagement to me would normally be an intensive care unit in a GP practice or a physiotherapy unit. And now my world has been about the front line for COVID, and that's very different. So I've spent a huge amount of time with the Scottish Football Association, with faith and belief leaders, with business owners. After I record this, I'm going on to a call with the business owners for Scotland about COVID certification. 500,000 people are involved in grassroots football in Scotland. So if you speak to the Scottish FA and use that communication to then get to that front line, you're instantly in homes and families all over the country. And if your message is about vaccination or testing or whatever it might be, that's hugely helpful. I've spent a lot of time with many groups. This is just an example of some of them. Individual disease groups. Young Scot is our charity for young people. They've done a lot of the communication with young people around vaccination, around school return, students, everything you would expect. So my front line has been very, very different. The third behavior is relentless focus. So quite a lot of my work has been on communicating. And this is the BBC and my vaccine, shortly followed in the afternoon by the First Minister's vaccine. So this is an optometrist doing a session of vaccination, and he wasn't expecting to be on the telly, but he was, unfortunately for him, on the telly. So the relentless focus on the comms and getting those messages across has been absolutely crucial. Our polling has stayed very high for trust in government messaging. That's not true in every country. And that's partly, whether you like the politics of the present government or not, it's partly about the First Minister realising that she couldn't do the communication just herself. She needed a clinician. And she never appeared at the podium in our press conferences without a clinician beside her. Often me, Catherine Calderwood, you'll remember the former CMO, and now Gregor, the present CMO. In Parliament, clearly she appears by herself, we're not allowed, and she gets questioned by opposition and the politics plays out. But when we've done public messaging, press conferences, we've tried to do that together. And that relentless focus has meant we've been able to get over some of these challenges. The other leadership skill in relentless focus has been in how the world has done what it's done. So the obvious example for a research group is in vaccine development. So, you could argue this is a good thing or a bad thing, and it's a little bit of a summary, but we moved all the clever people and pretty much all the governments into vaccine development. And we shrunk the time from 15 years, 10, 15 years, down to less than a year. And we did it by underwriting the research. So Pfizer or AstraZeneca would conventionally do their trials in sequence, not invest in the final product, not invest in the factory or the production until they knew the product was going to work. Governments came together, underwrote the work and said, no, go, compress the trials so we've got them sequenced, and here we are. We had a vaccine, a very, very effective vaccine within 10 to 12 months. Remember, a lot of vaccines didn't do this, didn't reach the end, and we don't use them. There were at one point 180 vaccine candidates, and they haven't all come to fruition. So we still have very strict criteria about whether you succeed or not, but we took some of them out. But the ones that have worked have completely changed the game, as you saw from the work right at the beginning from the data. Unfortunately, there's still a bit of work to do here. And the relentless focus now has to be on vaccinating the world. This is Our World in Data about the WHO's aim of getting 40% of the population of the world vaccinated by the end of 2021. So green is done, blue is on target to be done, orange is nowhere near. And you can see where those areas are. It's principally Africa, but there are little pockets, Papua New Guinea, some Central America. There are pockets here and there, but that's a problem. That's an absolute real problem, and we have to solve it. And it's not as simple as send them vials of vaccine. It's about logistics, it's about delivery, it's about going into villages with trained people, and you need more than a vial. You need a syringe and a needle and a sterile unit, and all the things that are a little bit more challenging in rural Ghana than they are in Edinburgh. So that's a big problem, and relentless focus is one of the ways we're going to manage it. So that's three. You've had person-centered, frontline engagement, relentless focus. Fourth is transparency. We've tried to tell the truth, and that's partly the press conferences. That's a press conference quite near the beginning when we had stay at home as our key message, and we did that every day, 7 days a week for a number of weeks and months right at the beginning. Now we've stripped that back. We don't talk to them quite so much. I think the only person still listening was my mum anyway. So now we do them more rarely when there's something perhaps more important to tell them. And data online. Public Health Scotland has what I think is an excellent dashboard. You can find your own postcode. You can look at the data in your area. And then the fifth and final behavior is boundarylessness. It's a made-up American word. Remember, IHI, American organization doing leadership. But you get the idea. It kind of illustrates what we mean. And to have a COVID response, you have to engage the whole of society. 5.5 million people here, and we couldn't have a COVID response if we didn't speak to community leaders and businesses and media, the charity sector, the police, and the people. We had to speak to the people. I've done a lot of phone-ins. I've done a lot of Q&As with multiple groups. I did one late into the evening this week with a radio station to hear from people and try and answer their questions, and then use their questions to try and help the broader population who happen to be listening. So that's the 5 behaviors: person-centered care or person-centeredness, and think about the population. Frontline engagement, where is the new frontline? What does that mean for you? Is it still the ward or the practice or the lab? Or is it something different? Is it bus companies that I've had to spend time with, or train organizations, or those who provide our energy services? Relentless focus, that's principally been for us about communication, but it's also been about the science, the relentless focus on the vaccine or the therapeutic or whatever it is we need to do. Transparency, so tell the truth, get the truth out there for the population. The population are not stupid. And if you can give them the information to arm themselves, to protect themselves about what to do, that's been hugely helpful. And that our polling would suggest that has gone relatively well in Scotland. It's not universal. Not everybody trusts us, but many, many do. And then boundarylessness. So break down the walls between the public and private sector, between research communities and clinical communities, so that we can use that fast and quickly, so that we can get that care out there. So those are my first 2 substantial lessons. Understand the problem and step in and lead. And my third and final one is, very briefly, breathe. It's about looking after yourself and others. So people are exhausted, not just in healthcare, but in education, in retail, and pretty much every sector you can imagine that's lived through this experience with us. So my wife's a teacher. She's homeschooled for some of the time. She's now back in school. She teaches English as an additional language to refugees and immigrants. She was an English teacher for 25 years. And that's hard. It's genuinely hard to do homeschooling for those who don't speak very good English is very challenging. So now back in the schools, but the schools are tired. They've had to adapt so quickly. I've got a pal who works in customer service in Asda, the big supermarket chain, and that is the front line. I've had to learn a lot about what a critical worker is during these months. And the people who keep our lights on, who deliver our food, who deliver our Amazon parcels, and everything else in between has been absolutely crucial. So you will be in that, your families will be in that. And it's important that we take time to look after our staff, but also the people they serve, the people they live with. This is our version of it. It's called Our NHS People. We have a website, we have tech support, we have a way of escalating to people. It's just one version of what that looks like across the NHS. Everybody has their own version. This is the Scottish adaptation of that NHS version, and this is NHS Education for Scotland, about looking after each other, what psychological well-being means and how it works. So those are my 3 lessons, but this is my very final lesson. So if you're approached by Doc and he asks you to type in the year you want to go to in the DeLorean, don't choose 2020. I think we could all do with leaving 2020 behind us in the main. But if you think that there's something in there for you, maybe it's in understanding what the problem is, leading into the problem. So step in and do whatever it is you can do to be kind, be data-driven, to be transparent, to be person-centered, and then finally look after yourself. My version of that has been 3 meals a day, sleeping 8 hours, and running 5K. Now, I'm not suggesting that prescription is possible for everybody, but that's what's kept me sane with almost no days off. So whatever your version is, I hope you can do it. So thank you very much for listening. Let me just stop sharing. So I hope the conference is a fantastic success, and you can come back from having made your tea now and listen to the next speaker. Thank you so much for listening.
That was fantastic. Thank you very much, Professor Leach. It's great to hear your insights and your unique experiences from Scotland. And thank you again for presenting to us, particularly on your day off, as it is St. Andrew's Day in Scotland.